My name is Mark Fulcher, and in this clip I'm going to show you how to examine the elbow of an injured athlete. The first thing we're going to do is spend some time having a look at Martine's elbow. So we ask the athlete just to stand nice and relaxed with their arms at their side. And one of the things that we're looking at is the carrying angle of the elbow. So there's meant to be a degree of elbow valgus. If someone's had a past history of an injury or trauma to the elbow, we may lose that. So we're having a look also for any wasting, scars or skin changes around the elbow and down into the forearm. And if we ask Martine to turn around, we can also have a look posteriorly at the elbow, having a look around the olecranon fossa, looking for any swelling, scars or skin changes in there. And so everything looks very normal. Having observed Martine's elbow, we're going to now have a look at a range of motion. So I think a nice way to do that is to directly compare both arms at the same time. So we're going to ask Martine to extend her elbows by her side, so we can have a look to see how much her elbow extends. Does it fully extend? Does it hyperextend? And how does that compare with the other side? And we'll ask you to flex your elbow. So having a look at full flexion, is there any pain with that, any loss of movement? And again, direct comparison with the other side. We drop your elbows down to the side. The other movement at the elbow that we need to consider is pronation and supination. So we're going to ask you to fully supinate, any pain or problems with that, and then fully pronate, comparing with the other side. And when I do that, I like to palpate over the radial head and see whether there's any pain or problems. So full pronation, full supination. The other thing I like to do while the athlete's standing up is to have an assessment of their collateral ligaments. I think it's a good way to do that using a chair. So if we ask Martine to lean on the chair with a little bit of elbow flexion, we can localize the elbow, lock it in, and apply a valgus and a varus stress, looking to see if there's any pain or laxity with those movements. And it's nice and solid. We'll then ask you to have a sit on the end of the bed there, Martine. So now I'm going to palpate some of the important landmarks around the elbow. So I'm going to start with the radial head because I think it's nice and easily identifiable. So I'll pronate and supinate the wrist, and I can feel the radial head moving underneath my thumb. If I move a little more proximally, we'll find the lateral epicondyle. That's a landmark which can become tender with someone with common extensor origin tendinopathy. Similarly, the medial epicondyle, if we palpate there, they may have pain with common flexor origin tendinopathy. And then we can palpate anteriorly around the distal biceps tendon, which is easy to palpate with the elbow flexed. Posterior to the medial malleolus, we can feel the ulnar nerve, and that structure we can feel rolling underneath our fingers. And then in the back, we can palpate the olecranon and the olecranon fossa and the triceps tendon. So if we're concerned about those tendons, we can assess the triceps tendon by asking Martine to push out against us. So push hard, no pain or weakness with that. If we're concerned about the distal biceps tendon, the best way to test that is with resisted supination with the elbow flexed. So make like we're going to shake hands, Martine. I want you to turn your palm up. I'm going to hold it where it is. So we're looking for any pain or weakness there. And we can see that as she does that, the distal biceps tendon is looking normal. One of the most common conditions we see around the elbow is an injury to the common extensor origin tendon or tendinopathy, known as tennis elbow. So there are a couple of special tests that we can use to assess for tennis elbow. We ask Martine to hold her arm out straight, and we're going to assess for resisted middle finger extension. So hold that finger out straight, stop me pushing the finger down. So if we push there and she starts to get lateral elbow pain, that's suggestive of common extensor origin tendinopathy. Same with resisted wrist flexion. And also there can be pain and weakness with resisted grip strength. So what I ask the athlete to do or the patient to do is to squeeze until it starts to hurt. If they squeeze really, really hard straight away, often it's very painful and that pain takes a while to go away. So squeeze just until it starts to hurt. So Martine's got excellent grip strength there, and we can compare directly with the other side. If they've got common flexor origin tendinopathy or medial elbow pain, we can get them to flex their fingers right up and flex their wrist up. Hold there, Martine. Stop me pulling your wrist out straight. One of the other things that obviously Martine hasn't had an issue with, but we need to consider is if someone's dislocated their elbow or has had a fracture around the elbow, we want to assess their distal neurovascular status. So is the sensation and motor function in the hand, are the pulses in the hand and wrist normal? So those are important considerations. So that's how I examine the elbow of an injured footballer.